remembers, can you hear me? Hello? Is the audio okay?
Yes.
All right. All right. So who remembers chapter 35? Was heart failure a primary disease, or did something else lead to heart failure?
Something else leads to heart failure.
Right. So it is. It was listed on table 35-1, if I'm not mistaken. So there were several causes of heart failure. We had an MI, we have valve disorders, pretty much the whole list in chapter 35. And then later, when we get to chapter 34, you'll also see that dysrhythmias can lead to heart failure. And then also again later in chapter 38, well, 38 is acute coronary syndrome, so that's the MI. And then later in chapter 37, you also see more causes of heart failure. So heart failure was called the definition was a state wherein the pump fails, the heart fails as a pump. It is no longer effective in producing cardiac output, and so the patient goes into a state of heart failure. Same thing, same concept in acute respiratory failure. This one, there are two types, but regardless, there are conditions here. There are two conditions that lead to heart failure. I mean, acute respiratory failure. I say two because the second bullet here actually says or, meaning it can be either or. Although there is a third type, which is a mixed between oxygenation and ventilatory failure. Anyway, so respiratory is a state wherein the patient has a PaO2 of less than 60 or PaCO2 of over 45, and the oxygen saturation is 90%. So if you meet these conditions, the patient is now considered to be in respiratory failure. So again, this is a state, okay? It's not a disease condition, meaning you were admitted, the patient was admitted for something else. Before I explain ventilatory failure, look at the causes, table 32-2. These are common causes of ventilatory failure. When we say ventilation, what do we mean again? What is ventilation?
Air coming in and out of the lungs.
That is the act of breathing. So the act of inhaling and exhaling. Now, if I show you column 1 and column 2. Column 1 are extrapulmonary, meaning these have nothing to do with the lungs. They are extrapulmonary. And column 2, you have lung conditions there. What do all of these have in common? If you remember from last semester, you talked about myasthenia gravis, the condition characterized by ascending motor weakness. No, sorry, myasthenia gravis is descending. Guillain-Barré was ascending. My mistake. So either in either condition, once the weakness affects the diaphragm, what happens to the patient? Or if in the case of poliomyelitis, this polio is referring to polio of the lung, not polio of the lower motor neurons, spinal cord injuries. This is of course affecting the cervical or high thoracic, wherein it will affect the diaphragm. Or if a patient has a stroke, as we just concluded, increased ICP, meningitis, or somebody overdoses on opioids, for instance, or have someone who has kyphoscoliosis, or really massively obese, sleep apnea, etc. And then on the column 2, what happens to the rate and the depth of the respiration in all of these conditions? Let's try a rate. What happens to the respiratory rate?
Is there any way you can like fix your microphone? It's horrible. There's an echo.
That's the best I could do. What happens to the respiratory rate in these conditions?
Increases.
Does it increase in Guillain-Barré syndrome or myasthenia gravis or in stroke?
Increases or stops?
Is it increase or decrease?
Decrease.
Decrease.
It actually decreases, right?
Yeah.
What about the depth? How deep are the breaths now? Are they still deep or shallow?
It's deep.
When you have myasthenia gravis,
Respiratory rate is deep, I think.
myasthenia gravis was progressive weakness with repetitive motion. In Guillain-Barré syndrome, when the ascending paralysis reaches the diaphragm, the patient is intubated. So what happens to the depth of the respiration in all of these? Or take, for instance, this one, kyphoscoliosis. So you have kypho, so you're bent over, plus your spine is also S-shaped. So if you have both of those conditions, what happens to your respiratory depth?
It's shallow.
So all of these conditions therefore lead to a decreased respiratory rate and also a shallow respiration. So that's why they fall under ventilatory failure, is because it is ventilatory respiratory failure is the failure of the breathing. The patient is not breathing effectively. They cannot, something inside or outside the lungs are preventing them from breathing normally. They cannot take deep breaths. They cannot have a respiratory rate of at least 12 to 20. They have decreased respiratory rate. They have shallow respirations. So how does that lead to respiratory failure? Of course, that will mean, although there will be no gas exchange problem, however, if you are breathing less though, even though your lungs are perfect, but you're not breathing at least 12 a minute, will you have enough oxygen?
No.
No. And can you, vice versa, can you also get rid of carbon dioxide normally?
No.
All right, so this is what this means here. So this leads to respiratory failure because the act of ventilation is not effective. Okay? It is inadequate. The actual air movement is the one causing the problem here, which is present in everything listed in table 32-2. The other type is oxygenation failure or a gas exchange failure. Again, I'd like to refer to the table 32-3. These are all causes of oxygenation failure. The problem here is either the oxygen is not available or the patient is unable to take it in, meaning this is a failure of gas exchange. Number one is, first bullet is high altitude. So of course those conditions here have low oxygen. So even if you're 100% able to ventilate, oxygen is simply not available. On the second bullet going down, these are conditions where the actual act of gas exchange is impossible. For instance, if you have pneumonia, so there are now exudate and fluids inside the lung because of the bacterial invasion. So therefore, gas exchange is affected. In the case of CHF with pulmonary edema, now the lung is wet, so therefore gas exchange is also affected. In the case of PE, which we just concluded last week, there is an actual mismatch here. There is no blood getting to the lung, therefore there is no gas exchange. There is hypoxemia, and we can go on down the list. So here, this is an actual gas exchange failure. So most of these are lung problems, at least most of them, except for the first one here, which is there's no available oxygen. There is a combined example. The ones listed here are in COPD, for instance, or even in asthma. or cystic fibrosis. So there are a few instances wherein they will have both ventilatory as well as oxygenation failure. In either case though, what are the criteria again? When can we say the patient is now in respiratory failure? What's the PaO2 again?
PaO2 less than
60.
Less than 60. Or the PaO2 is over
60.
45. And then in both cases, what's their oxygen saturation? Less than 90. So if your ABG results in any of these, then you are now in respiratory failure. This will be quick because what the intervention, of course, will be, as far as respiratory failure itself, the only treatment is oxygen. So you provide oxygen support. Whether you meet that, whether you do that by cannula delivery or a simple face mask, or if you go full mask, rebreather, and then you go non-rebreather, and then positive pressure ventilation using non-invasive means for CPAP, BiPAP, or if needed, then you intubate the patient. In all cases here, again, how you treat respiratory failure is oxygen therapy until you can treat the underlying cause. Of course, the respiratory failure will not resolve unless you treat the underlying cause. So the causes, of course, are listed in tables 32-2 and table 32-3. The rest of these, the signs and symptoms, if you look at it, they're not really, in no way are they exclusively found in respiratory failure. This could be anything. In all patients with hypoxia or low oxygen saturation, you will have mental status changes. So that's why you have restlessness, irritability, agitation, confusion, tachycardia. These are all present in pneumonia, COPD, asthma. These are non-specific to respiratory failure. So this is just somebody who has very bad hypoxemia or very bad hypercapnia. So as far as signs and symptoms go, nothing specific. But the intervention, again, is only oxygen therapy. Along, of course, with the treatment for those conditions in the tables table 32-2 and table 32-3. In addition to oxygen, the other treatments are also supportive. What did you do for a patient with pneumonia? Did you give them nebulizer treatments, bronchodilators? Yeah. Yes. Did you give them steroids?
Yes.
Yes, for the
Did you
inflammation.
position them in the orthopnic position? Yes. So again, the interventions here are nothing specific to respiratory failure. These are anybody with a hypoxemia problem, with a gas exchange problem. So you position suction as needed, you provide postural drainage, you increase hydration, and of course contraindicated if it's caused by a heart problem. You give expectorants, you do incentive spirometry, you do postural drainage, etc. And that's it. Any questions on respiratory failure?
Professor,
Yes, boss.
so we can actually give a bronchodilators, and also maybe if they have some asthmatic issue, maybe we can give the albuterol, like 2 puffs like that.
Yeah, like I said, the interventions here in the signs and symptoms are nothing specific to respiratory failure. It's the same assessment findings and interventions you give for any patient with respiratory condition. The only other treatment that's different is specific to the cause. What led to the patient's respiratory failure? So you treat those conditions again listed in table 32-2, table 32-3.
Thank you.
Okay, let's go on to ARDS. This
Okay.
is again another
I have a question.
condition that, go ahead, sir.
Sorry. On table 32.3, the last bullet all the way at the bottom is complications of nitroprusside therapy. Could you explain that? The last bullet, the toxicity and the methylhemoglobinemia.
Okay, this is regarding, this is specifically due to nitroprusside therapy. We will discuss this under shock. That's chapter 37. That would be week 12, I think, right after our third exam, because it's kind of long. Actually, I will start mentioning this in chapter 38 because nitroprusside is also given. This is a vasopressor. We give it under chapter 38 for patients with experiencing cardiogenic shock secondary to myocardial infarction.
Okay.
But remind me later. It's just a long story. I don't have time today.
No problem.
Okay, let's go to ARDS. So as defined here, thank you for reading, Mr. Kimmins.
Acute respiratory distress syndrome, ARDS, is acute respiratory failure with these features. Hypoxemia that persists even when 100% oxygen is given. Refractory hypoxemia, cardinal feature. Decreased pulmonary compliance, dyspnea, non-cardiac associated bilateral pulmonary edema, dense pulmonary infiltrates on X-ray, ground glass appearance.
Okay, so that's the answer. We will discuss all of these one by one. So first of all, this says the definition is, it is acute respiratory failure. So this is the ABG of this person will still have a PaO2 of less than 60 or PaCO2 of over 45, and then definitely the oxygen saturation here is less than 90. On top of that though, unlike respiratory failure wherein when you give oxygen, the patient responds to oxygen and therefore it gets better, this patient no longer responds to oxygen. Before I move on to the others, let me go here. So the cause of ARDS is acute lung injury. Now, the causes of acute lung injury, although there are some mentioned here, these are the most common. So the most common causes of acute lung injury are sepsis, burns, pancreatitis, trauma, and transfusion. You have a longer list here though, table 32-4. So all of these lead to acute lung injury. Now I want you to remember, we don't see lung. I've never seen lung sold in the grocery store. I only see liver, kidney. I've seen kidney, all other organs, but I've never seen them sell lung. My guess is it doesn't taste good. That's gotta be it. I mean, why else wouldn't they sell it, right? Anyway, if you imagine the closest organ to the lung is the liver. So if you imagine the liver, you see, what color is it?
Liver. It's black, I think.
What color is the liver?
Purple,
It's like
a burgundy-ish
a
color.
burgundy, yeah.
So closer to red, right? Of course, you're looking at a dead liver. If it was alive, what do you think that color will be? If there was blood running through it,
Bright red.
it'll be very red. Okay, so the lungs are the same. The lungs will be very red because it's very vascular, right? So although, look at these conditions here. The first row versus the second row. Now, in all of these conditions, although some of them are nowhere near the lung, I mean, look at the pancreas, for instance. That's in a totally separate system. I can understand this one, pulmonary aspiration. So if you somebody vomits, for instance, they're drunk, they're passed out supine, and then they start vomiting, and then they aspirate their own vomitus. Imagine pouring down a very acidic solution down that really red, soft cushy lung. What will happen to that lung if you pour acid down it?
It'll destroy the tissue.
Yeah, definitely, right? Will that
Cause
be
ARDS.
direct? Yeah, will that be direct lung injury? Will there be injury to the lung?
Yeah.
Yeah.
Yeah, definitely.
Yeah, definitely. Okay, so that one is direct. However, there are several indirect sources or causes of acute lung injury here, meaning they're not directly injuring the lung. However, they do so via sepsis. Sepsis is the number one or the most common factor in all of these. For instance, if you undergo a pulmonary infection or you have pneumonia, for instance, or pancreatitis, have a dirty organ there that gets inflamed. I mean, a sterile organ connected to a dirty system, meaning the GI tract is dirty, but then the pancreas is clean, right? I mean, it's sterile. It's only secreting digestive enzymes, pancrease lipase, but it is connected to a very dirty GI tract. So when that thing gets inflamed, of course, the patient will go into sepsis. And then sepsis, in turn, will lead to severe inflammation. So what I'm trying to say is the explanation is right here. So those conditions leading to acute lung injury, let me explain this highlighted paragraph. So what will happen say this is a capillary. So with sepsis, for any of those conditions there, trauma, burns, are these, by the way, those conditions, look at conditions listed in table 32-4, are they minor?
No.
No.
These are severe injuries, right? So will they trigger a systemic or a local inflammatory response?
Systemic.
Systemic.
Now imagine each of the blood vessels, whether it's an artery, the vein, or capillary, becomes very permeable. Because normally, if these are your capillaries, and then this is the alveolus, this is an air sac, are they permeable to large molecules, like proteins, for instance? Do protein molecules normally go in and out of the vessels?
No.
No, they can't. They're so big. It's impossible. They're just way too big. They cannot pass through. However, in conditions such as sepsis, this now causes SIRS. This is later though in chapter 37, but this is what was going to happen. Actually, this was discussed in liver failure because it was the same concept in liver failure. Anyway, so the patient has severe inflammatory response. This therefore changes the capillary permeability. So we have now an increased capillary membrane permeability. This condition is self-limiting. We don't know though how long. Typically, this may last 24 hours for some patients. This could be 36 hours in some patients, or even longer. We don't know. That's the problem. We don't know how this response by the body to a severe injury lasts. Until then, we don't have the means to stop it. You've probably seen this in the reports about COVID-19. So this is the same thing. So COVID-19 is a serious injury. It causes the same exact change. It causes severe inflammatory response syndrome, leading to increased capillary membrane permeability. So now large molecules such as albumin, for instance, now leaks out of the bloodstream. So now you have albumin, which are protein molecules, and the problem with that is when albumin leaks out, water always follows it. So now you have water going with each of these albumin molecules. And as described in the paragraph, you have also other debris there. Now sugar and other large molecules also follow suit. As a result, water fills the lungs. So if you go back to the definition, one was the first, the definition was ARDS is acute respiratory failure with the following characteristics, right? The following features. Number one was hypoxemia refractory to oxygen, meaning they don't respond to oxygen therapy, which makes sense. If this is now the alveoli and this is now the capillaries wrapping the air sac, how can gas exchange occur when there is water here? So as oxygen enters, can they enter the water? Can they penetrate the water and then go into the bloodstream?
No.
No. You can fart. So let's say this is Harry. If he's underwater, yeah, he can fart here and then air can escape here. So CO2 may be able to escape, but oxygen cannot enter. Right? So this is the reason why there is hypoxemia refractory to oxygen therapy. It does not, they cannot have gas exchange. It's impossible because there is now water everywhere. Now imagine we're only talking about the lung here. This leaking of the capillaries is also happening elsewhere in the body. So at the same time, you will also see leaking. The patient now has edema all over the body as well. So you'll see more of this in chapter 26 when we talk about burns, because it will actually, because this is the same type of injury. Burns, in fact, one of the complications of burns is ARDS. So this is what it means here by there is now injury to the alveolar capillary membrane, leading to all these debris, proteins, and fluid to enter the alveoli now. Normally, lungs are dry. They should only contain air. But then now the patient has fluid in it. So if a dry lung appears how on the x-ray? When you see an x-ray film, what do the lungs look like? What color are they? What color are the lungs on x-ray?
The air is like black and then the bones are white.
Very good. The bones are white because they're solid, and the lungs, because they're air-filled, is black. Now, look at what happens here, as defined here. How does the lung look like now? They now look like a white-out appearance. They have ground glass appearance. So like if you literally ground glass, no matter what type of glass that is, it will appear white. So when you take serial x-rays here, take an x-ray today, x-ray tomorrow, x-ray another day, you'll see a difference. The lungs here will get progressively white and white with each succeeding x-ray. There is also decreased pulmonary compliance. Compliance is a pliability of the lung. So here the lung, is it still soft or more stiff now? Because it's now filled with water. Is it still soft? Its mouth is now very stiff. So is it easy or hard to ventilate a stiff lung?
Harder.
Extremely hard. So the pressures here, when we put this patient on a ventilator, there will be high pressures inside the lung, causing the doctor to increase the pulmonary inspiratory pressure in order to deliver the air. We'll discuss that. Hopefully we have time today. If not, we'll continue next week. Definitely there will be dyspnea. Now let's go to the non-cardiac associated pulmonary edema. So let's go back here. Now, why do they call it non-cardiac? Because what's the cause again of the water accumulation here? How did this water get here? What was the cause? How did the water enter the alveoli?
Because of the albumin regulating the oncotic pressure and pulling the water inside it.
Very good. So this is caused by the increased capillary membrane permeability. This is what caused the water to enter here. If you recall chapter 35 in heart failure, because there was also pulmonary edema in heart failure, was it the same cause? Was there severe inflammatory response in heart failure causing increased capillary membrane permeability, leading to water accumulating in the alveoli? Do you recall this thing happening in chapter 35? It wasn't, right? So what happened in chapter 35 was, excuse me. So what happened in chapter 35 was there was congestion in the heart. So as the heart failed, so all four chambers of the heart now is filled with blood. It is now congested, no blood is moving. Meanwhile, there's plenty of blood trying to enter from the SVC and the IVC. But the heart is filling its pump. It cannot pump blood out, nor can it take in any new blood. So there's congestion here. There's also congestion in lungs. So again, what's the cause of the pulmonary edema in heart failure versus the pulmonary edema in ARDS? Were they the same mechanism?
No.
No, this one is simply the heart here is fine. If you put a pulmonary artery catheter inside this patient in order to monitor pressure inside the heart, what do you think the numbers will be? So let's go in heart failure. In heart failure, what happened to the right atrial pressure as well as the pulmonary artery wedge pressure?
Increases.
It was very high because there was congestion here. There's congestion here. So when you put a diagnostic catheter in there, you put a swan catheter, it will register very high RAP, or also called CVP, and your PAWP or PAOP numbers are extremely high. Here in ARDS, because there is no heart failure here, what will those numbers be? In heart failure, you said they were high. What happens in ARDS? If you put an pulmonary artery catheter here, what will those numbers be? What will those pressures show?
Normal numbers.
Either low or normal in ARDS. So this is how you distinguish. Okay, this is because when this patient comes in and you take an X-ray, look exactly, you'll see congestion, you'll see pulmonary edema. Pulmonary edema is pulmonary edema, no matter what the cause. However, distinguish whether this is heart failure pulmonary edema versus ARDS pulmonary edema, you put in a catheter and then you'll see based on the numbers, this is not caused by a cardiac problem. This is something else. And the only other most popular cause, plus you add the patient's symptoms and the history, then you conclude, oh, this is ARDS. So ARDS is a more of a sequelae. This is now a complication from just like respiratory failure. So this can result from all those causes in table 32-4. You can add COVID-19 to the list. So any question on the features? Again, the number one cause of ARDS is acute lung injury. Then the causes of acute lung injury, whether directly or indirectly, are listed in table 32-4.
And you said we could add COVID-19 to that list, Professor?
Yes, sir. The only difference is most conditions, as you'll learn later in chapter 37, steroids are not indicated in the case of ARDS secondary to sepsis. Yeah, and it's really controversial because the patients really have no benefit based on evidence. However, what we're hearing now is on the news, what I'm seeing is the acute lung injury caused by COVID seems to be responding well to dexamethasone, which is a steroid. So this is really something new. The COVID patients seem to be responding to steroid therapy, which is not seen. That's why when they tried it, a lot of doctors were skeptical because that really doesn't work. You know, we know that doesn't work. However, they're out of options. They tried it and it seemed to have a good benefit for COVID patients. So it's working. So they're using it. Mortality of ARDS is really high. In fact, when the pages, again, there are several causes mentioned. On top of table 32-4, you have here conditions that are likely. Number one is sepsis. And sepsis is a complication of several other causes like anemia, pneumonia, for instance. You go septic after getting pneumonia. All of these lead to ARDS. Now, the mortality is quite high. If you look at this here, your textbook is 2015. So this, this one says 2016. At 2016, 4 years ago, the mortality is still 42%. Now, this is 2016. This is not 1962. All right, in 1962, the mortality wasn't any better. It was maybe 51%. But look at the period though. Consider all the advances we have now. We have way better ventilators than they had in 1962. But yet this is the best we could do, drop it from 51 to 42%. So you can see how bad ARDS mortality is, meaning it's better prevented rather than treated. Again, the cause here is until now, we have no medicine for that increased capillary membrane permeability. We don't know how to stop that because that is really what triggers all these. We've already seen responses from interleukins. So let's say in rheumatoid arthritis, for instance, we have treatment for that now. We have IL-6, interleukin-6 medications. You have adalimumab, for instance. We have tumor necrosis factor medications. Now we can stop those. But the increased capillary membrane permeability response, the capillary leak syndrome, we have no suppressor for that. We still don't know how to stop that because that's really what's causing the patient's symptoms. Until then, the best approach here is really to prevent ARDS in the first place. Because once it sets in, patient has poor prognosis when that starts. Just like in respiratory failure, the symptoms here are not specific except that the patient does not respond to oxygen here. So this is one thing you will notice, that no matter how much oxygen you give this patient, they won't respond. Okay, the oxygen saturation doesn't improve, lung sounds stay the same. And there's something here, please read this as a warning. Mr. Espinosa.
Yes. Highlighted part.
Yes, please.
Abnormal lung sounds are not heard on auscultation because the edema occurs first in the interstitial spaces and not in the airways.
Okay, so this is just one warning that when you listen to the lung sounds, you may not hear abnormal lung sounds early on because there are phases in ARDS. You may not hear it early on because, again, the water, the pulmonary edema actually isn't inside the alveoli yet, but they will eventually make their way there. Diagnostic tests, of course, we draw the ABG, then we look at the everything we talked about earlier. So they will put the pulmonary artery catheter in, they take serial x-rays, they look at the patient's ABG. If all these changes are occurring, then clinically also when we hear the lungs are already really sounding wet, then they make a diagnosis of ARDS. Here, so they'll take a series of x-ray once daily, and then when they see this increased opacity until the patient's lungs now appear white out, then they make a diagnosis of ARDS. So if you read here, there's really no one diagnostic test that will isolate ARDS. It's all a combination of the patient's clinical symptoms. Interventions, just like respiratory failure, we're not treating, because ARDS, what's the cause of ARDS again? Those listed in table 32-4. So those are the ones that you try to treat, try to control, because they lead to acute lung injury, which leads to ARDS. I already mentioned there are phases, but I'm not testing the phases. You can skip that. So just like in respiratory failure, our treatment here for respiratory ARDS is mainly supportive. We keep the patient alive by giving oxygen therapy. Once ARDS is already, a diagnosis of ARDS is made, the patient will have to be intubated. We will discuss all these later in the chapter after the break under mechanical ventilation and airway management, because whatever they say here are going to be repeated anyway. But let me just point out a few things because they are not mentioned under mechanical ventilation. One is this one, positioning. The evidence shows that a patient with ARDS that's on prone position has a better outcome. This is possible when you have an intubated patient and you put them prone. Of course, this will require a lot of work to turn the patient prone. However, magnet hospitals do have mechanical turning devices. They have beds called roto beds, which rotate on their own. And they rotate 360 degrees. So of course, the main thing there is to strap the patient, make sure they don't fall when the bed turns. But the evidence here is the more you put them prone, the better the lung heals, because the fluid doesn't stay in the dependent areas of the lung. So this will help drain. This will actually promote drainage of fluid from the lung. Another is as far as fluids go. Thank you for reading this section, Miss Brittany.
Research shows that patients with ARDS who receive conservative fluid therapy have improved lung functions, has a shorter duration of mechanical ventilation and ICU length of stay compared with those who receive more liberal fluid therapy. Conservative fluid therapy involves infusing smaller amounts of IV fluid and using diuretics to maintain fluid balance, whereas liberal fluid therapy often results in an increasingly positive fluid balance and more edema.
Okay, thank you very much. This makes sense because if you recall the increased capillary membrane permeability, every drop of water that you infuse into this patient, these patients are intubated, so they're NPO. So every drop of fluid you give IV into these patients, where will that end up? Where will that water go if you have increased capillary membrane permeability? and then you're giving IV fluids, where will that fluid go?
The lungs, alveoli.
It will go straight into the lung. So is it helping or is it making your condition worse?
Was
Making it worse.
Actually worse. However, the patients do need fluids. These patients are NPO. Although we have a feeding tube, however, that's not going to be enough. You still have to give them IV fluids. So therefore, this is what it's saying, that there should be only conservative fluid therapy. Based on evidence, conservative fluid therapy has a better patient outcome compared to those wherein you're giving so much IV fluids. All right. And as already mentioned, these patients will be given tube feedings. Although parenteral nutrition can be an option, but however, it's not the best because this one, TPN, has a high risk for sepsis. And this patient already has enough sepsis to deal with. So as much as possible, we use enteral nutrition only. Take a break. We'll continue with airway management at 2:05. I'll see you in 17 minutes.
thank you, Professor.
All right.